Hello, everyone. This is Dr. Tony Scuderi. I'd like to give you a presentation today on dialectical behavioral therapy, also known as DBT. During this presentation, I want to introduce you to the concept of DBT as a model for treatment for clinicians, both new and seasoned. We'll take a look at some of the DBT skills that are out there, and I'd like to discuss with you whether DBT is an appropriate treatment for substance abuse patients. This is virtually a new way of treatment, a new way of thinking, even though it's been around for quite some time in dealing with patients outside of borderline personality disorder, to which this was intended to be. Marsha Linehan from the University of Washington is the creator of DBT, and her primary purpose was to treat complex patients that had a chronic history of parasuicidal and suicidal tendencies. So these patients with borderline personality disorder are among the highest lifetime prevalence, and they have the highest lifetime prevalence of completed suicides. This is approximately 10% of those people with this disorder, and that's a pretty significant number. Borderline patients often exhibit high levels of anger towards others, especially during the treatment, and the anger is projected towards their providers, therapists like you and like me. Lower levels of treatment adherence they have, and they'll come into treatment, they'll stay for a while, things will start to get better, and then all of a sudden you'll see that they'll start to leave, or they'll just drop out permanently. And at this point, they usually have a very high risk, high level of suicide. Borderlines are very costly, and most service providers are reluctant to either pay for their treatment or try to barter you down from the fee that you want. It takes a lot of time, it takes a lot of energy, and on the therapist viewpoint, it takes a good bit of commitment. So DBT integrates or synthesizes several things: behavioral therapy and acceptance-based strategies. So we have CBT, and you validate the patient, and cognitive behavioral therapy plus the validations to the patient, it gives you the practice of DBT. It's an Eastern thought. It takes Zen, and meditative practices of Zen and the Western philosophies, and binds that into cognitive behavioral therapy. And then there are different types of worksheets and exercises that the patient can do to hopefully gain better control over themselves and their impulses. Biological or transactional based models for borderline personality disorders range from like biological to genetic and social and environmental variables with treatment, all have influences over everybody over time. So all of these things, the biology, the genetics, society, environment, and the variables within the environment that come in and attack the patient, influence the patient and the patient's behavior. So as a transactional model, there are two factors that influence the biosocial model in it. First of all, you have emotional vulnerability, and you have emotional dysregulation. So how vulnerable is the person emotionally? Do they have control over their emotions? And the answer to that is usually they do not. And this inability to control their emotions leads to an emotional dysregulation. And as it leads to that, it invalidates the family, the social environment. So as it invalidates the family and social environment, the person becomes very, very lonely, very scared, very detached, very hopeless and very helpless, because there they are all alone with their feelings, and they have no idea what to do with these feelings or these emotions. So this is called emotional dysregulation. So in 2001, Linehan basically stated that emotional dysregulation has three parts, and these three parts have to be present in order to make a diagnosis of emotional dysregulation. First thing is high sensitivity to emotional stimuli, very high sensitivity. So when emotions come in, the person doesn't know what to do. They're very sensitive to them and they act out on them. They can't control it. The next is high reactivity to the emotional stimuli. So in comes this flood of emotions. They don't know what to do with it. It's there. They're not sure what they're feeling or if they're feeling anything, right? And then they react to it. And the third one is a slow return to baseline, which basically means once they start reacting to it, to come back to what we would consider normalcy or normality takes a real long time. So Linehan claimed that patients with emotional dysregulation have these extreme difficulties. And these difficulties range from modulating arousal, psychosocial arousal, and all those versus what is reality. So we have an arousal coming. They don't know what to do with it, right? And what this does is the outside arousal, the social arousal, mixes in and meshes with the psychological arousal, causing a physiological response, and that causes the confusion. And as that causes the confusion and the irregularity or the dysregulation, as she calls it, we take a look at that and we see the norm on how people should relate, and we try to figure out from there how we can pull this modulating arousal, psychological arousal into the norm, because it's just not there. So there's a lot of inhibiting, dysfunctional, impulsive moods that happen. So their moods are there, they're dysfunctional, they're very impulsive. Borderlines are extremely impulsive. They think that things are working, they're not working. It causes a great bit of dysfunctionality, and we take a look at that in retrospect or in respect to dependent actions, a way that they can move from the inability to dysfunction and these impulse control disorders into dependent actions where they can now move from dysfunctionality to functionality. So she also believed that part of emotional dysregulation was this titration to emotional intensity, where the person becomes extremely intense, extremely emotional, buys into that, and that's the only thing that they can work out of. So we try to move them over to either escalate or blunt emotions. And this is what we see in the borderline personality. So this organized behavior that they have, or I should say this disorganized behavior that they believe is organized behavior, we need long-term goals. And we need to take a look at these long-term goals, and we need to measure them and balance them against short-term emotional arousals that the borderline has. So one of the things that we look at in borderlines is this invalidating family or social environment. And as we take a look at this invalidating family social environment, we take a look at this pervasive invalidation, where they criticize, punish, ignore, anything else you could think of. That's the pervasive invalidation, all right? And then we take a look at valid behaviors such as desires, wants, emotions, and responses of that individual person. And as we look at that, we have to develop over time or present at this time throughout the patient's lifetime a way that we look at these invalidating behaviors, begin to understand them, and begin to have the patient take a look at these behaviors and hopefully turn them around. So, generally speaking, these invalidating environments can ignore or punish a patient's expression of pain or negativity. And as they do this, it reinforces extreme pain. The patient may oversimplify the difficulties of their tasks, or they may control or suppress the natural emotions that the patient should have, but they somehow have repressed or suppressed these. So the ultimate goal of DBT takes a long time. And the ultimate goal of it is for the patient to understand that instead of having a life that is absolutely horrendous and horrible, to have a life that's worth living. And the way to do this is we have to take a look at it, and we have to get the patient to see different types of targeted behaviors that we want them to accomplish. So our treatment plan is developed, and it's based on strategies that correspond to the disorder that they are experiencing. Okay, so we take a look at these strategies, and we break them down into stages, and we target the behaviors that interfere with the goals that can be accomplished in each of these stages to get the patient out of their poor behavior patterns into a different type of behavior. The primary target behavior and the secondary target behaviors, we take a look with what is known as a behavioral chain, which Linehan calls a chain analysis. So let's take a look at some of these stages, right? So the first stage of this is what we call behavioral discontrol. And the goal behind behavioral discontrol is to take a look at all relevant areas of the patient's life. What worked for the patient, right? And we want to take those parts that worked in the patient's life that are relevant to the patient, and we want to target behaviors that cause stability and safety within those areas of life. Now, sometimes the relevant areas of life are not good areas of life. It could be self-destructive acts. We want to take a look at these acts, and we want to target behaviors that the person can work in so that they can become safe and they can become stable. Some of these are life-threatening behaviors, as I mentioned, right? Suicidal, parasitical, suicidal thoughts, aggressiveness, violence, extreme agitation, out of control anger. The person becomes the victim, or the person can become the perpetrator, right? So one of the things that we look at is therapy interfering behaviors. These are behaviors, as we're studying the patient, working with the patient, that interfere with our treating that patient. The patient may refuse to come to sessions. The patient may act out. The patient may project to you that you're the worst person in the world, et cetera, et cetera, et cetera. So our goal in dealing with therapy interfering behaviors is to help the patient achieve stability and to bring out of control the things that are out of control into control, that they control, not anybody outside of them. They first have to understand that the behaviors come from within, and those behaviors that come from within, those choice behaviors, are out of control behaviors. And those behaviors don't control them. They have to turn around and they have to control that behavior. The second stage of DBT is what we call emotional misery. So PTSD, post-traumatic stress disorder, the patient suffers from emotional pain that's due to traumatic causes. And these traumatic causes can be anything, right? Abuse, neglect, denial, punishment. And then we can go to wars, insurrections, tragedies within society, car accidents, seeing people having traumas placed on them, murders, suicides, rapes, all of that stuff. So what we want to try to do is reach a target behavior to decrease the avoidance or to stop escaping from emotional stimuli and effectively learn to manage these emotional issues without becoming overwhelmed or affectively flattened by these experiences. Life happens. And the person that happens to be a borderline just doesn't know how to handle life as it is. Everything is catastrophic. And they get to a point where they start to believe that what they're doing is the right thing, and the only way to do it, what everybody else is doing, is the wrong thing. And they can be very convincing to get somebody to believe that what they're believing is incorrect when it is. So the idea is to get them to recognize this overwhelming behaviors that they have and to work through it, and to get their affects that have been flattened and to animate them a little bit more. So part of this deals with relapse prevention and the question of relapse prevention and what that's all about. So the first thing is, why do patients relapse back to the first stage? In other words, back to the behavioral discontrol and their need for behavioral control over everything in their life. So patients often relapse back to that. Why do they do it? Because they want to respond to the traumatic experiences. So if relapse occurs, treatment focuses on that first stage, taking a very careful look at the behavioral discontrol and the behavioral control over their relevant life, and try to stabilize that for the patient. So at the completion of the second stage, emotional misery, the patient may be involved by having a supportive, validating environment, like good relationship with family, good relationship with friends, a good relationship with their therapist, good relationships with their significant others. From there, once they reach to that, we move into Linehan's third stage, with life on life terms and dealing with it as it is. It is what it is, and they can't change it. They can't control it. They have to stay within that environment. They have to understand that this happens. This is life. I'm in the middle of it, and I have to just breathe and deal with it. So the target behavior of dealing with life on life terms is to learn to deal with life's problems, which the borderline can't do. So problem-solving skills are taught. Problem-solving skills are used. For example, resolving problems with education. Maybe they have a difficulty in school, focusing, memorizing. It can be pathological. It can be like ADHD, attention deficit hyperactivity disorder, or it can just be who they are, right? Or maybe there's a trauma is so much inside them that it blocks their ability to understand and to comprehend things. Employment difficulties. They can't keep a job. They go part way, get distracted, start to fight, start to argue, sabotage, and next thing you know, they're fired. So we got to work on that. We got to improve on that type of stuff, especially with working with others, because a lot of the relational problems that borderlines have is dealing with others. They can't cope with that stress. So the fourth stage of Linehan learns to manage incomplete feelings. So the idea is to take a look at the feelings that the borderline has within them and to teach them to manage it, right? A little bit of, what are they doing? Why are they isolated? Pull away from the isolation. Teach them to get outside of that isolation. Teach them a little bit about intimacy. Let them become intimate first with themselves, understand what's going on inside. Accept that. Self-acceptance is one of the keys in this. And as they accept themselves, they learn to accept others outside, which gives them a sense of meaning. Okay? What kind of meaning do they have about themselves? So the target behavior in this is to sustain happiness, to be content, and to have a sense of joy, right? So the four content areas that we're taking a look at in the skills that we're trying to train the borderline to have to become more of a whole person are mindfulness skills, emotional regulation, stress tolerance, and interpersonal effectiveness. These four skills are extremely, extremely important. And if they can manage these, they can start to manage life a lot better and be a lot less self-destructive. So how do we go about doing this? Well, we go about doing this, first of all, with behavioral chaining. And then we begin to accept and to validate the person. And this begins with mindfulness skills. Mindfulness skills is very, very prominent in Linehan's treatment of borderline patients. And I believe also mindfulness can be in the treatment of any mental health disorder and or substance abuse disorders, because these skills center on learning and observing and describing and participating in all experiences that they have. And I mean all experiences, including their own thoughts, including the way they sense things, their own sensations, their own emotions, and the things that happen to them externally in the environment. All of these things need to happen without judging the experiences and without deeming them as good or bad. The therapist cannot judge. The therapist has to teach the person to interact and to start to observe, describe, and participate in these experiences, reaching to a whole individual. So these are considered by Linehan to be the core skills that are necessary in order to implement the other DBT skills that we're going to talk about and to integrate them successfully. So to begin all this stuff, she takes a look at what I think is actually brilliant. She breaks it down into a Venn diagram, and there are three parts to the Venn diagram. If you remember from your high school days or grade school days when you learned about this stuff, you got three circles and there's one in the middle that's intersected. Well, if we take a look at the three circles, we have in one part of it something called the rational mind. On the other side of it, we see this is the emotional mind. And these are usually the two minds that these patients work out of, one or the other. And that's where the problem comes in. We as human beings cannot work totally out of a rational mind. We can't be logical and rational. That's very difficult to live that, to see everything mathematically perfect. So that's difficult. The next thing is we can't really live in the total emotional mind. We can't see things totally out of control. We can't see things totally emotional. That can be problematic. The emotional mind is totally out of control, completely out of control. All feelings, all emotions, all agitations, all anxiety, everything that's outside that's there is totally out of control. And there's nothing to balance it. That's where a lot of suicidal behaviors come in, because when you start to get this flood of emotions that comes in, it's very difficult to try to sort through them. You'll usually get when somebody says, when you ask them, how do you feel? I don't know, I'm all over the place. Or, they may not say, I don't know how I feel. And this buries the feelings. Now, when this happens, eventually the affect becomes flattened. And the person, this is where the scary part comes in. You'll see on a lot of borderlines that they'll start to superficially cut. And if you ask them, tell me what it feels like, they'll basically sit there and say, I don't feel a thing, So why do you cut? Because I know that there's something inside there. I don't know what it is. And I'm all bound up and I'm all tense. And when I cut, I get a sense of relief. Wow. Now, this is where the fatality comes in, because sometimes if they cut, they may cut too deep, injure a nerve, cause paralysis in that area, or they may cut an artery, and the next thing you know, they're dead. So what do we do with mindfulness? Mindfulness takes the rational mind, takes the emotional mind, and pulls them together so that when we become too rational, we draw from the emotional. If we come too emotional, we draw from the rational. And then we make a decision based on the rational and the emotional minds, and we pull them together, and this she calls the wise mind. So when we see the wise mind in action, basically we're seeing is a person that is in total control, rational, or total discontrol or disconnect, emotional, pulling together so that they're both rational and emotional. That's how people act in the real world, and that's how we think. We are both rational and we are both emotional. You can't be one or the other. We're everything. So in the middle of the Venn diagram, we see the wise mind. So the wise mind is the joining of the rational and the emotional mind. So in mindfulness skills, we see two types. The first skill she teaches is what's known as the what, W-H-A-T, the what skills. These skills observe, describe, and participate. That's what these three things do. They observe what's happening, what is happening, right? They describe what is happening, and then they participate in what is happening. And then once they get all of these things together, then what winds up happening is they learn how to deal with what is happening. And this is the second mindfulness skill, the how skills. And they deal with them in a non-judgmental way. It is what it is. You take it as it is, right? There's one mindfulness, that's the emotional, the logical brought together, right? And how to deal with things effectively. using that wise mind and emotional mind pulled together, or I'm sorry, the emotional mind and the logical mind pulled together in wisdom. Okay, so these two skills, right? The what skills, the how skills are extremely important. Again, the what skills: observe, describe, and participate, right? In what's happening in reality. The how skills: how do you deal with reality in a non-judgmental way, using a wise mind and making your decisions very effective decisions, right? So let's take a look at the what skills for a moment. So let's observe. That's the first part of a what skill, is what we observe, what we see. Now, Linehan calls this the Teflon mind. Now, the Teflon mind, if you know anything about Teflon, you put it on there, things just slide off, right? You're making an egg on a Teflon pan. You don't need to put any grease on it or any spray or oil or anything. You crack the egg on it, you swirl the thing around, and it just slides right off it. And you look at the pan, and the pan is clean, right? That's a Teflon pan. The Teflon mind works the same way. You let feelings and you let thoughts come and go. Now, the borderline will make them come and stay, and then they want to deal with it right there, and they can't. You've got to understand that thoughts and feelings come in and they go. As you're doing this, you need to be mindful of what's happening here, how you think, feel, smell, taste, touch, your five senses. So you're aware of everything around you. You're aware that you're feeling something. You allow that something to come in, how the external stimulus comes in and affects you. And then once you start to understand how that is, and it goes around in your mind, you sit here and say, I've got a feeling. This is what happened. I can't control this. This is starting to bother me. It's really starting to bother me. What can I do? Wait a minute. What am I feeling right now? Well, I'm starting to have racing thoughts. I'm starting to breathe heavier. I could feel my heart racing, right? I'm feeling a little bit sweaty here and agitated, right? And I'm starting to really hear things, maybe hypersensitively, right? And I can't control it. Wait a minute. I can't control it. So let me take a deep breath. Let me exhale, and let me let it go, because I can't control this. This is what's happening. This is called the Teflon mind. Okay. The other thing that borderlines and some people that are in the midst of an addiction, sometimes in mental health crisis, they cannot describe what they're feeling. They know that there's something going on. I feel terrible. How do you feel? Can you describe it? I can't describe it, but I know I'm feeling absolutely horrible. Right? So what we need to do is we need to teach them to put those words or those feelings into words. I feel terrible. Well, tell me what terrible feels like. What's that like? Can you put a color on it? What's the color that you feel in terrible? Oh, it's red? Okay. So what does red mean for you? If you look at the color red, what does that mean to you? How do you define that? Good. Now, how do you take that definition that you just did and put it inside you? What part of you feels red? Oh, your stomach? Okay, right in your stomach, your abdominal region. Tell me what that's like based on it's a red stomach. What does that mean to you? And then you listen to the patient. You listen to what they say. And that's just one example. I like to use, different colors. Red is very intense. Yellow is kind of like I'm getting there or I'm not getting there. It's kind of neutral color. And then you have blue. Blue is like it's all good. It's nice and clear and perfect, right? So that's one thing. Describe. Have them teach them how to describe their emotions. And if they don't know their emotions, get yourself a sheet. It's an emotion sheet. You can get them online very easily. Just type in your browser window ideas of emotion sheets, and you'll see these little happy faces with smiley faces and frown faces and flat faces and all different things, and they'll put the emotion underneath it: happy, sad, mad, glad, disruptive, agitated, angry. And you sit there and you tell the person, here, take a look at this, hold on to this, and point to the one that you think you're feeling. And then they'll point to one, you sit here and say, tell me what that's like. What does that feel like inside? So you're having them describe that feeling that they never really knew that they had, right? So now you're using everything in your power, the visual to allow them to get visual external, to allow them to get to the visual internal to see what they're feeling. And then you want them to participate in that. You want them to get involved with the process, not just to sit there and have you say, what do you see? But to have them sit there and say, look, I don't know what I'm feeling, but here's the emotion right here. This is the feeling that I'm having in this picture, right? So that gets them to participate. So therefore, what happens is they name it and they claim it for their own. We used to have an old saying back in the 70s and the 80s. You know, when I first started learning psychotherapy and counseling, we used to say, own it, claim it, name it for your own, right? Name it, claim it, own it for your own. And that was another one also. And that way, what happens is it cuts down on the racing thoughts that you may have, that they may have. It begins to get the person to learn how to accept things that they cannot accept, that things are there, and they have very little control over it. And it also changes the reactions to the situations that they have. So now instead of panicking and getting parasuicidal, or in the case of addictions, panicking and going out and using, they have more control, understanding that they cannot control what's going on around them. And the main idea and the concept is to get them to move out of it. How do you do this? Well, these are the house skills. Once they have that part and they see that they need to feel and they need to get these things to move out, how do you do it? Well, borderlines and other people have a high tendency to judge things, right? This is why it's happening. I'm a bad person, or they're a bad person and they do this to me all the time, so they become the victim. So the way to attack things, the way to teach them is to be non-judgmental. Don't evaluate. Don't sit there and say it's good. Don't sit there and say it's bad. Don't say it should be this way. It shouldn't be that way. Don't judge. There's no need for this. It is what it is. Don't non-judgmental. You look at the situation as the situation is without definition. One of the things that I do is I'm a judge. And I'm a judge on an interjurisdictional canon law court. And I'm also, if I have to litigate, I'll litigate for in certain canon law cases. As a judge, one of the things that I have to do when I'm on the stand is I have to listen to everything. I've got to be able to see the person as they're experiencing the reality in that moment. And then I have to listen to the defense, and I got to listen to the prosecution, and I have to listen to their reality on how they interpret the victim or the defendant's reality. And then I have to be able to sit back and I've got to filter all of that out, because some of it is very emotional. And believe me, prosecution sometimes can be very, very convincing. It's their job. And so can defense. But as you're listening to the prosecution tell the story, sometimes, your guts turn and you're sitting over there going like, yeah, this person is definitely guilty. You got to put that aside. And you just have to sit there and listen to what they're saying and listen to what defense is saying. And as you're listening to both of them, you're seeing the wise mind, the rational mind, and the logical mind and the emotional mind, in play. And as you do that, you got to sort through it, and you've got to pull them both together, get rid of the junk, and see everything as it is, the wise mind. And that's where the decision and the judgments are made. And you don't have to agree with it. Judges don't have to agree with it. All we have to do is follow the law. This is what the law says. Now tell me how this law was violated. And you got to sort out all the crap, and you come to what violated. Well, that's what you're doing here in one mind, right? One mindfully. You're doing things one thing at a time. You're not being judgmental. You're doing things one at a time. You're sorting through it. You're understanding it. What this does, the other part of the house skills, is once you do that, once you approach things non-judgmentally and you do things with one mind, sorting out everything and pulling it together to the wise mind, Then we start to see the last part, which is how things are done effectively. So the patient has to focus on what works and what doesn't work. Needs to get rid of the things that don't work and just focus on the things that work. As in court, when I'm looking at a case, I have to look at the rule of law and I have to play by those rules. Well, the patient looks at the rule of life and has to play by the rules of life, and you can't make it up. You can't sit there and change the rules in the middle of the game. It just doesn't work that way. And you also have to understand that things aren't going to go the way you want them to go. If you're in a courtroom, defense wants it their way, prosecution wants it their way. Prosecution wants the person put in jail or fined or something. Defense wants the person out of jail on their own and the case dropped, right? Two poles. That's what they want. And it's my job to sit there and to look at this, and they're both very angry, at one another. Prosecution is angry at defense to defend this person that should be in jail, and defense is angry at prosecution. How dare they prosecute this innocent person that I'm defending? And you got that conflict going. And here we are in the middle as judges sitting there looking at this going, I don't know, what do we do with that? Well, what we do with that is we sit there, we let go of the anger, and we look at the facts. And this is what you got to teach your patients to do. Let go of the anger, look at the facts. What this does is it decreases vengeance. It decreases vengeance, it decreases the agitation, decreases the anger. And it also decreases righteousness thinking, right? Everybody is not right and everybody is not wrong. So once you understand how to get through to the facts and how to understand what the facts are going, this righteousness goes away, and now you work out of the wise mind. So emotional regulation skills, what they do is they get the patient to identify and to manage their emotional regulations, or their emotions, to regulate them, I should say. That's what emotional regulation does. See reality the way it is, you take a look at it, you learn to identify it, you remove yourself from the situation. Even though you're in the situation, you understand that this is the way that it is, and you have to work through that difficult period instead of having that difficult period work on you. And the way to do that is to manage your emotional reactions to that situation. And this is one of the things that the therapist and the clinician have to do. They have to teach the person to work through that. So how do we do that? Well, there's a thing called a please master. Linehan was brilliant, with these things. It almost reminds me of Mr. Rogers, as he used to sit there and say, and would you be my friend? And he would always be positive. I like you. You're a nice person. You've got these wonderful gifts. Will you be my friend? Well, this is called please master. First of all, the P in please master starts with physical illness. The person has to take care of themselves. A lot of times, mental illness, borderline personality disorders, drug addicts, once they get latched into the disorder, they forget about the body and they focus more on the illness than on getting better on themselves. And some of the things that they do to make them think they're getting better is just making them worse. So the first P skill, if you will, is physical illness. You need to start working on getting yourself back in shape, eating well, exercising, talking, getting a therapist, working through your problems, looking at reality, understanding that it's not you all the time, that you are part of it. You're being victimized, but you're not a victim. And that's another thing, is to stop being a victim. That's part of your emotional regulation. Because if you're emotionally dysregulated, you're totally the victim. So in your P skill, your physical illness, you want to take care of that to de-victimize yourself. Next one is the E skill, right? The E skill is balanced eating. So you're balancing eating. You don't have too much. You don't have too little. Your little snacks on the side there, you do it in moderation. You don't gorge, right? You don't binge, you don't purge. So you take a look, you make sure with the P skill that your physical illness is taken care of, your body is taken care of. Your E skill is your balance, your eating. E is for eating. So you balance the eating. Because sometimes when you're depressed, you can go one of two ways. And when you start getting self-destructive, you can go one of two ways. And when you start to get into your addiction, you go one of two ways. You either become healthy and you forget this stuff, or you become totally dysfunctional and you abuse this stuff. You abuse this stuff, this is where now you start to have more of a low self-esteem and a poor self-image. Think of the person, if you're binge eating, you look great, you're buff, you're happy with yourself and all this, and all of a sudden you start to get depressed and you start to eat and eat and eat and eat and eat and eat. And all of a sudden you start getting bigger and bigger and bigger. And now you hate your self-image, you hate your body. You hate your body, you got this body dysmorphic thing going, and you hate yourself because you're eating, you're binging, which makes you feel like a bad person, and everybody's looking at you. You become very self-conscious. So then you let yourself go. You start to feel a little cold coming on. Now, the heck with the cold, it really doesn't matter anyway. And you become sicker and sicker and sicker. You see how things build? The next thing in the Please Master is the A, right? The A is to avoid mood-altering drugs. Stay away from illegal substances. If you're not an addict or an alcoholic and you do these and you like to drink, do it in moderation. And understand what moderation means, right? You sit there and you go to the doc, and the doc asks you, do you drink? And you say, yeah, well, I have a glass of wine. How much do you have? Well, regular glass of wine, about that big. It's all just one glass. One glass, that's all. Instead of it being like this big, one glass of wine. That's not moderation. You know what I mean? So the idea is to do things in moderation. If you do things in moderation, you take care of yourself, your body is there, you start to understand what you're feeling, and that's feeling a little bit better. You're eating better, your body looks good, you're avoiding all these drugs, you can sleep better. You got balanced sleep, right? There's nothing worse than not being able to sleep. Did you ever do a cocaine rush? You do a cocaine rush, you're up like this all night long, 24, 48 hours. And then all of a sudden you can't sleep. You start to crash and something happens there. Or if you're depressed, you may be up all night because you got racing thoughts. And so you eat to take care of the racing thoughts, right? Again, here's the reality of the situation. Take a look at it. Get exercise, something, walk, get out there. Walk, if you've got a pool or a gym, take advantage of it. Don't just turn around, take advantage of it. You don't have to, people sit there and say, do a regular routine. Sometimes you don't have time for it, but you always have time to get up and take a walk, right? You don't have to go far, clear out the cobwebs. If I'm working an 8-hour day or a 12-hour day, I got to get up and I got to get out. I don't care if I go out my front door in my house and just walk to the corner or walk to the edge of the driveway and then walk back in, and then go to my office and continue from there. At least I take a break. The body needs to rest, and it also needs to exercise. One of the worst things that a borderline can do or a drug addict can do is have a sedentary job. Because now you're going to get fat, you're going to start getting sore, you're not going to have any contact with anybody, and there's going to be issues. After all that, build mastery. That's the next stage. Try doing one thing a day that you're good at, stick to it, and feel competent. Understand that you're not going to get it the first time, and you're going to have to do it over and over and over again. And that gets extremely frustrating because we as human beings want it now, right? I'm 65 years old. I'm just learning how to play the piano and trying to do the violin. The only problem with the violin is the darn thing fiddles with me, but I'm trying to learn it. And there's nothing worse than sitting there 2 hours a day or an hour a day running up and down scales when you got this beautiful piece of music in front of you. When can I play this? I want to play it now. And then you stop running up and down the scales and you take a look at the piece of music and you're sitting over there going like, I can't read this. It sounds beautiful if I play it on tape, but I can't read this. In order to build mastery, you have to start with the basics, and you've got to stick with the basics over and over and over again, and then build on the basics. Once you start to build on the basics, then the piece comes together. Even the most simplest piece in the world, take Twinkle, Twinkle, Little Star, right? And we all know what that sounds like. Even that simple piece on the violin can be horrible. Where do your fingers go? How do you hold the violin? How do you hold the bow? How do you draw the bow? Where's my first finger go on the violin? What do I do with this? I mean, it gets very complex after a while, and it gets very frustrating. But if you do it one note at a time, you go slowly, right? Real slow. Sounds like heck. But after a while, you start to move. And as you start to move, now the piece comes into play. And then after a while, 2 weeks, 3 weeks, 1 month, 2 months, guess what? Twinkle, Twinkle, Little Star, you learn how to play. And you learn how to play it not only one way, but you learn how to play it where people sit there and go, oh my God, that's really nice. It's like Twinkle, Twinkle, Little Star. But what you've done is you've mastered it and you started slowly. This is how you do addictions. To build mastery over your addictions, don't try to go big. Start slow and build on the basics. Once you build on the basics, it works. It's the same thing with mental health issues. If you're being medicated and you've got a good therapist, you start to build on the basics on how to feel better. You keep going to therapy, take your meds on time, do little exercises that the therapist tells you to do, take a look at things, be honest with yourself and your therapist when they ask how you're feeling, and work through the things. Build on the basics. You do this, then you have interpersonal effectiveness, right? This focuses on interpersonal effectiveness, focuses on learning to successfully assert yourself and to manage conflicts in relationships. All relationships first with yourself and then with others. I believe fully that in order to have a good relationship with somebody else, you need to have a good relationship with you. You need to understand who you are and have a good relationship, accept the good, the bad, and the indifferent and the difficult, the good, the bad, and the ugly, as the show goes. The reason for that is if you can do that, then you gain self-tolerance. And once you start to gain self-tolerance, the logical and the emotional mind come together to the wise mind. And when that starts to happen, you begin to get some self-understanding because you filtered out the rest of the stuff and you now know what the difference between reality and fantasy. And you now know the difference between functionality and a functional dysfunction, right? So in interpersonal effectiveness, what happens is once you learn yourself and you understand how to work with yourself, then you can relate to other people and you can accept and understand where they're coming from. And this is what draws the people to you because we all need friends. And some people don't have friends because they don't know how to make them because they don't know themselves. So how do you get what you want? That's the big thing here. How do you get all this stuff? Well, there's a little, I don't know what you call it, acronym or something that Linehan came up with, another interpersonal skill. It's called Dear Man, DEARMAN. It's not a sexist thing, so don't go there, okay? It's just, Dear Man. So the D in Dear Man basically describes the current situation. Tell me what's happening in the right, here, and now. That's your Buddhist philosophy. Because don't forget, dialectical behavioral therapy takes CBT. Buddhism pulls them together, right? So this is the first part of it. Describe your current situation. Tell me what's happening now. The E, once you describe it, express it. Express your feelings, express your opinions. But when you express them, And I say this all the time for people in group when they sit there and say, well, you know, when you do this, stop it. I stop it right there. And I say, no, I don't do that. Can you say I when I do this? Because what that does when you say you in a group situation makes you very safe. It takes reality and puts it out there somewhere on that person. And you may sit there and say, well, no, that's not what the person means. Well, then say what you mean. Don't give me a you when you mean an I, right? So part of expressing your feelings is to make I statements, right? Not you statements, because now I name it, own it, and I claim it for my own, right? It's now me. When I get upset, this is how I feel. Not, well, you know, when you get upset, you feel, no, I don't feel that way. And that's another thing, you know, for clinicians. Never say to your patient, oh, I know exactly how you feel. You don't. You really don't. You may have an idea of how that patient feels based on your own experience of that type of feeling or that type of situation, but you don't know what that person feels because you're not that person. So don't say, well, you know how you feel when this happens? No, I don't. How do you feel? Please say, this is how I feel, and get the person used to saying, I feel. In the beginning, it's going to be very difficult for them to say that, but over time, what's going to wind up happening is they're going to get so used to it, they're going to sit there and they're going to say, well, I feel, and whenever I'm in this situation, I do this. Instead of, you know, well, you know, the way you feel when you're in a situation, you do this. No, stop that in the beginning. Don't let them finish the sentence. The A part of Dear Man is to assert yourself. Ask for what you want. You know, sometimes borderlines and drug addicts can be, you know, even mentally ill people can be very complacent. You know, doc, tell me what to do. What can I do? You know, that's why I'm paying you. You know, tell me what to do. I just don't know what to do. No, I'm not going to tell you what to do. If you've ever watched the video of Carl Rogers, it's a very old video. It's Rogers, I think it's Rogers, Erickson, not Erickson, but Ellis. Rogers, Ellis, and Fritz Perls with this one patient. And the patient goes to Rogers, you know, and she sits there and she says, Dr. Rogers, would you please tell me what to do? I don't know what to do here. And Rogers sits there and goes, well, you know, Gloria, her name is, I think. No, Gloria, I can't answer that for you, but I'll sure help you reach some type of an understanding, you know, that you can make a good judgment on. And this is exactly what DBT does here. It asserts yourself. So when you assert yourself, you know, you want to be able to say what you need to say, but also you need to take your own stance and say no when you mean no. Unfortunately, in some situations, when you say no, that could be, you know, no to a relationship, no to a drug, no to a feeling, no to an impulse. It can be a very scary thing, but at the same time, it's a very necessary thing. Assert yourself. Assert yourself in the positive to say yes. Assert yourself in the negative to say no. And now I have the last part of Dear Man, the dear part, the R. We reinforce this. So how do you reinforce it? Well, in therapy, you know, we know from our behavioral treatment, right? Behavioral therapy, stimulus response, SR therapy, that the way that you get an appropriate response from somebody to reach their target behavior, you give them reinforcement, either positive reinforcement or negative reinforcement, positive punishment or negative punishment, right? You reinforce the behavior. And once you reinforce the behavior, you extinguish or you get rid of the invalid responses that the person is having to try to accomplish the target behavior. You get rid of those, and the only thing you have is the pure response, and the target behavior is achieved in the most expeditious way and the most valid way. So you want to reinforce, you want to reward the person. You know, you want to do this ahead of time. You know, when Skinner used to reward something, he used to say, if a dog wanted food, he would say no. You know, food would be on the table. Dog was for food. No, take it away. No, take it away. No, take it away. Notice what I'm doing. Tapping the table. No, take it away. Then all of a sudden you would go, no, no food. And then no, goes after the food. No. Then all of a sudden you would just go, and that would be it. The dog wouldn't touch the food. Right? You reinforce, and then you reward the behavior. Good boy, way to go. You know, simple training, behavioral therapy. Explain the consequences. Let the patient explain the consequences of what's going on. This is another part of reinforcement. You know, there are consequences to every action. Good behavior, there's good consequences. Bad behavior, there's adverse consequences. But there's always a consequence to an action. And that consequence is a one-to-one correspondence to that reaction. This is why one of the things that you want to train the patient in doing is to get what they want to get and how to get it, right? Take a look at the positive, take a look at the negatives, and what's the most efficacious way and safest way to get what you want. Weigh it. Take the emotional mind, take the logical mind, hold them together, get the wise mind. Reinforce that behavior. So get them to describe the event, get them to express themselves, to express what they're feeling and what they're going through, get them to assert themselves, tell me what you want, yes or no, it is yes or it is no, and then reinforce that behavior. Once you do all of that stuff, then we go into the man part of it, right? Where you stay within the moment. We call this mindfulness. You stay within the moment. You stay on your objectives. Do not deviate from them. This is what I want. You know, if I want to get sober, this is what I have to do all the time. And when I start getting those feelings of relapse, this is what I have to do to stay sober, stay on track. Be mindful of your situation right now. Don't be distracted, right? Don't try, to go back to playing those tapes, those broken records in your head. And then when you have the temptations that come along, for the drug dealers to try to convince you, what you don't want to do is you don't want to buy into that. You want to ignore these personal attacks, right? And as you do that, you grow through it. So as all of this is happening, you appear confident. That's the A part. Appearance is everything. The way things appear, that's 100% of your reality, how things appear. Be effective, look effective, look confident, watch your nonverbals, watch your verbals, watch your posture, know what's happening here, right? Because every move that you make is being registered by somebody on the outside. Have good eye contact and pace yourself. Breathe well. When you speak clearly. Those are two things people can't understand what you're saying because it's just all anxiety. They can't understand the anxiety because they're therefore immersing too much. And also, you don't want to talk very slow. Because if you do that, you've lost the person within about 3 seconds and yourself. If you appear confident, take control. When I teach people how to do public speaking and I put them in front of a crowd, one of the things I tell them is look over their heads. You own that crowd. That crowd doesn't own you. Even if they boo you, you own that crowd. They can't hurt you when somebody gets a gun and shoots you. Right? But if it's just people that are there to agree or disagree with you or listen to you, you control that crowd. You're the orchestrator, right? Be very positive about that. The end part of the dear man, the end part is to negotiate. When you negotiate, you're not going to get your way all the time. Can't insist. A good relationship is a give and take relationship. Yes, you're going to get angry, but it's going to be a controlled anger, or you're going to get angry and you're going to understand that, you've lost this time. So you walk away, take a breath, and you come back, right? You negotiate it. You get happy, you're happy. Right? You got to give a little to get a little. It's the old song. I'm not going to sing it for you. Okay. But if there's something that you don't agree with, you don't just sit there and say, I don't agree with you. No. And stand by that. No, I don't agree with you. What about this? For example, if you're in therapy, when I treat patients, I'll listen to the patient. I'll sit there and say, well, how do you want to, or what do you want to do to recover? What do you want to do to get better? What would it feel like? All these different questions. And they'll tell me, and I'll listen. And if it's good, I'll just, make a note of it and move on. If it's not good, I'll say, well, hold on just for a second. So you're telling me you want to do this. Is that realistic? Do you think it is? Okay. You think you can do that? Well, what if you did this in addition to this? How do you think that would work? So I'm giving my suggestions. I'm giving an alternate solution. And then I'm having the patient practice it in the right here and now. Could be role play, or could be, when you come back next week, let me know how it worked. It could be one of those things. Eventually, you're going to ask the patient, is there another way you can think of that? Because I'm not sure it really sounds the way it should work out. Is there another way you can word that? And then they'll word it a different way, and then you reinforce that if it's appropriate. That's your end. That's your negotiation, right? With all of these skills, what the idea is to somehow learn what it's like to have a relationship with, as I said, yourself and somebody else. So the next bit of this is when we have relationship effectiveness skills, right? How do we do this? Well, in order to have a relationship, what is a relationship? It's a give and take response to somebody. I give some, I take some, they give some, they take some, right? So there's give skills that Linehan comes up with. The first one is gentleness. Be courteous. Be courteous. Be temperate in your approach towards others. You don't have to have your way all the time. You don't have to have verbal or physical attacks if you disagree with somebody. You don't have to threaten somebody. And God knows you don't have to judge somebody. It's the old thing that my folks used to tell me. You point one finger at somebody, you got at least 3 others back at you. One's forward, 3 are pointing back at you. Don't judge, lest ye be judged. Right? Be gentle. I respectfully disagree with you. Well, I hear what you're saying, but I'm sorry, that doesn't work for me. It's a lot different than, shut the hell up, what's the matter with you? Screw you, you don't know what you're talking about. I don't want to listen to somebody like that. In fact, I want to walk away from somebody like that. Well, somebody sits there and says, doctor, I don't agree with what you're saying right there. My next response is going to be, oh, okay. Let's talk about this. What's up? Don't ever demand from me. You demand from me, you're not getting anything. You negotiate with me. Wouldn't you like to be negotiated with? How would you like it if I demanded from you? Try teaching sometime and demand things from your students and watch what you get. Bark an order at a student and watch what you get, especially in this day and age. You don't do that. You negotiate. You be gentle. Hey, I'm not really happy with the performance that you're doing right now. Your grades aren't where they should be. Now let's talk about this. What's going on here? Can I help you? As opposed to, you better sit down and you better do your work. Because you don't do your work, you're going to flunk. And I really don't care. Really? Well, then if you don't care, neither do I. That's not showing courtesy. That's being very verbal in a negative way. And that can lead to arguments, fighting. And then you as the person, whatever it is, not necessarily in the classroom, but even in reality, for one little thing, you can start judging that person as a real creep. Now you got problems because what if it's a nice guy or gal? Show your interest. I don't want you to not only hear what the person is saying, I want you to listen to what the person is saying and be interested in what others have to say. Borderlines have a hard time doing that. Borderlines have an interest in one thing, themselves, and what they can get and what they can say. Borderlines with narcissism, and out of control narcissist. Listen to people. Validate people. That's a big thing. You know, validation, the acknowledgement of the other person's feelings is essential. What do they feel? Validate it. Good, bad, or indifferent, doesn't matter. Validate that feeling and then pull them out of it if it's a bad feeling. What do they want? What do they really want? What are their difficulties? What are their opinions? You know, listen to them. Don't be judgmental. Listen to them. Debate them. Socratically question them. Have a conversation with them. Be dynamic with them. The moment that you turn, you're very rigid and loud, you've just lost the person and yourself. Because if you do that on the outside, I wonder what's happening on the inside. How loud are you on the inside that you're not listening to your feelings and your emotions? How judgmental are you on the inside when things are out of your control and you have no control over them? You just have to accept that and move through it. And when you approach people, do it in an easy manner. You got to teach people to chill a little bit. This world is too tight, too tense. You know, it's the old joke. It's, you know, you're like a teepee in a wigwam. Yeah, you're too tense. Stop being too tense, right? Ease it up a little bit. Have a little humor in there. Smile a little bit. Be lighthearted. Be jokey. You know, not all the time. I mean, there's an appropriate time and an inappropriate time to do it. Yeah. But you don't want to be a wigwam. You don't want to be a teepee. Right? You don't want to be too tense. And I'm not trying to be facetious here. I'm very serious. And this is what you've got to teach your patients. You know, accept the things that they can accept and accept the things that they cannot accept. Because what does this do? Well, when a person is out of control and they don't accept things, they become very distressed. So one of the skills that Linehan teaches is distress tolerance. It's another skill. Distress tolerance promotes learning and different ways to accept and to tolerate distress without doing anything that'll make the distress worse, you know, especially in the long run. So you get all pent up inside, you get all distressed, you get all anxious, and you act out on it. And then you act inward on it. You act inward, you start getting things like heart attacks, ulcers, you know, joint pains, headaches, migraine headaches, cluster headaches, tension headaches. You get all this stuff, all this neurological crap happening to you. Externally, you start cutting. You start all this behavior that's self-destructive. Internally, you've got the racing thoughts. You relive things from the past in the present. And you keep dead people that no longer can harm you very well alive, and they continue to harm you. You don't know how to let that go. The psyche is a very, very fragile thing. Once it gets damaged, it can take a long time for it to heal. And as the psyche starts getting damaged, if you're not learning distress tolerance and you don't know how to manage that distress, you know, go to where you need to go when things start to happen, then you start to bury those emotions, you suppress those emotions. And eventually what happens is they get so buried in there, they get cognitively forgotten, but affectively remembered. And as they get affectively remembered, they start to split. And this is where we start to see dissociation come in and complex trauma. So one of the things that you need to do is you need to teach people how to tolerate distress, to understand that things are happening. Yes, you can panic. You're allowed to get scared. You're allowed to be frightened, but improve the moment. So when you improve the moment, think of the word improve, right? Imaginary. That's your eye. Imagine things, step back from things. Go into the, in Latin, we call it the imago, the imagination. The image, the internal image. Imago means image. And you go in your mind for that image. Relaxing scenes. Deep breathing. Close your eyes. Meditation. Look at a beautiful painting. Right? Imagine the color blue. Right? Imagine the comfort. Imagine that. Decrease distress. The next thing is the meaning. Create some purpose, some meaning or value to the pain that you're feeling, emotional or physical. What are the positive aspects of pain in the painful situation? How can you grow out of the pain? If you're in emotional pain, what are some of the pain positive aspects of that painful situation? It's not pleasant, it hurts. But what are some of the positive things that you can get out of it? Can you become stronger through it? Can it teach you to stay away from that type of person? If that person violated you, that type of person? Because sometimes what happens with people that have been violated and have been abused from childhood is they don't have a pain positive experience. Their idea of pain positive experience is to go back to that same type of personality, and it could be on an unconscious level that caused the pain. So somebody that has an abusive father may start dating somebody that's abusive to them and may not know how to handle somebody that's not abusive to them and will sabotage that relationship because that's their comfort zone. And this is where they have a fear of success. I can't feel good because all my life I felt bad. Now, pain positive aspects of it would be women. When this happens to me, I don't feel good and I want to feel good. So whenever this feeling comes upon me, whenever something like this happens, I need to do something different so that this goes away so I can self-soothe, so I can feel good about myself and what I do. So I'm not going to hang around that kind of person because whenever I meet this kind of person and I fall in love with that kind of person or I like that kind of person, I know where it's going to lead me. It's going to lead me right into having a problem situation and right into my self-destructive behaviors. Wow, that's a positive. Because now you realize what you got to stay away from, you realize the consequences, and you realize that if you go there, there's going to be issues, and if you stay away from there, it's going to be great. The next part of improvement, prayer. I mean, I could talk forever on that. I happen to be a bishop, Catholic bishop in the Ecumenical Catholic Church of Christ. I could talk to you all day about prayer. But what do you do with people that don't understand prayer? Well, do they understand a higher power greater than themselves that can lead them to sanity? What is that higher power? Can they meditate? Can they look at something and find relaxation and peace? Something outside of them, greater than them? Because we as human beings, don't only exist in the physical, we also exist in the spiritual. And we can't see the spiritual, we can only see the physical. But we know the spiritual exists. And that's a big part of us. Physical, we can draw from the physical to build our physicality. You want to get muscles, go to the weight room, right? You want to get a more powerful brain, go read a book. Well, what do you want to do with the things that you can't see? You feel down, you feel out. You got this hurt inside. It's not physical, it's more of a mental, spiritual thing. What do? Go to a power greater than yourself. And I'm not talking about a doorknob. I'm talking about something above you, outside of you, greater than you. A doorknob is not greater than you. I had a patient one time that sat there and says, oh, I stay in recovery. You know, every time I want to use, I go and I kneel down in front of a garage door and I pray to that handle and it goes away. Well, good for you. You know, then there's going to be one day where that handle is not going to answer you. If the handle does answer you, then come to me and I'll send you to a psychiatrist, right? But if that handle does answer you, you're going to have some problems. And then what are you going to do when there's no garage door around? Huh? Did you ever think of that? What if you're driving in the middle of the desert and there's no garage door around and you need something? You need a power greater than yourself that's inside internally, a spiritual power. And you need to relax in it. You need to relax into that power. One of the other things that you can do to improve the moment is stop. Do what's known as systematic desensitization, right? And one of the ways to do systematic desensitization is to start from the tip of your head to the tip of your toes and take each part of your body, tighten them, take a deep breath, tighten it for a moment, focus only on that area, loosen it, feel how nice it feels loosened, and move down to the next portion. Do the same thing, and the next portion, and the next portion, and the next portion, and the next portion, and keep doing that throughout your body. Inhale, exhale, relax. Systematically get rid of all the anxiety. Systematically desensitize the tension from you, which is a little bit different from systematic desensitization through reciprocal inhibition. That's another thing I'm not going to talk about, but it's a little bit different from that. What I'm talking about here is systematic relaxation or relaxation therapy. Relax the mind, relax the muscle groups. Take some time for yourself, okay? Do one thing at a time in this moment of time. Take one thing at this time in this moment of time and accomplish it. And that is really hard for people with ADHD. Because just when you're starting to do something in this moment of time, your mind wanders and you got to do something else, and this doesn't get finished. And then your mind wanders from that, and you got to do something else. Now you got two things that aren't finished. You just started a third thing. And as you're starting a third thing, the fourth thing comes up. So now you've got 3, 2, 1, and 4 that's not done yet because your mind is going, beep. One thing, force yourself to do that. It'll cause anxiety. When the anxiety comes in, stop, relax, go back to it. It doesn't work all the time, but it works a lot of the time. And if it doesn't work all the time, go to somebody, talk to somebody, see if there's something else you can do or something that you are missing. I'm a terrible test taker. I've got 5 doctorates, right? But I'm still a horrible, horrible test taker. And you give me a multiple guess test, I don't know what to do with it. Standardized tests, I'm even worse at. But you give me something verbal, I'm great. You know, that's how I pass my tests. Give me a verbal. And I'll tell you, I talk your ears off because I know the material like that. What you put on paper, I'm useless. You give it to me in reality, I know what to do with it. But you put it on paper, I'm useless. I know that about myself. And every time I have to take a test, I go into a panic attack. And what I have to do is I've got to sit down, I've got to breathe, I've got to relax, I've got to make that not my enemy, and I've got to start to think a little bit more clearer on what to do. One thing at a time, one moment at a time. If you look at the word improvement, it's got a V in it. V doesn't stand for victory. V stands for vacation. Not necessarily saying 2 weeks away, but when we're dealing with a vacation in the improvement of the moment, We're talking about take some time and pull away from your work. They got to pull away from your work. This is one of the reasons why some state and federal laws sit there and say, no, if you're working full time, you need 2 15-minute breaks and you need at least a half an hour for lunch. Used to be an hour, but they cut it back to a half an hour. You don't get paid for it, but you need it. Why? Because the mind's got to reboot. I remember when I was studying for my ham license examination, ham radio, I did one of these things called a ham cram. It's where you get all the questions that can ever be asked on the ham radio licensing exam. And you start at 7 o'clock in the morning and you go to 4 in the afternoon and you read the question. It's A, B, C, D. They got the answers right there. You highlight the answers in yellow and you move to the next one. You keep doing it. And then when you're done one page, you review that 3 times. And then you move to the next page. You review that one 3 times. You go to the next page, you do that. And when you're done one whole section, you then go back to page 1, review that a 4th time, and then you go to the next section, you do that, and then you go back to the first one, and you do this all day long. And at 4 o'clock, you sit down, you take the test, you're exhausted. Some people do great with that. I don't. Some people do great with that. They can sit down, they can take the test and pass it. It's a 35-question test, but you've got like 300 questions they can draw from. And you got to know all 300 questions. Well, if you have recognition of the question and the answer, you've got the answer and you can finish it in 3 minutes. Well, you take a vacation because during that period of time, what the instructor would do is he would have us do the ham cram, and then he would say, okay, take a 10-minute break. Everybody out of the room. 10 minutes. 10 minutes, you come back. Okay, start working. You work for another couple hours. Okay, everybody stop. Out of the room. 10 minutes. And then when you're done, okay, lunchtime, you got a half an hour. Back here in half an hour. So you're rebooting the brain. Well, you also reboot your emotions. Take time. Pull the covers over your head, if you will. Take time. Lock everything out. Reboot yourself. Reboot your heart. Reboot your emotions. Reboot your mind. Right? And the E in improve, encouragement. But not from somebody else. Be your own cheerleader. Encourage yourself. I'm a good person. I'm a bright person. I really did this. I can do this. Boy, am I the best damn thing this creation has ever seen. Yes, sir. I am good. Right? There was a song back in the 60s and 70s. I think it was done by Diana Ross or something. The Supremes, I am strong, I am invincible, I am woman. Remember that song? Well, that's what this is talking about. Use that. Remember, focus on the I, not the you. I am a good person. When I was an altar boy, we had these little buttons, and it was ILAC. I'll never forget. The assistant pastor gave me his. It was a yellow button with black letters, ILAC, and he stuck it on my collar. And I thanked him. I said, "What does that mean?" ILAC. It goes, I am lovable and capable. Ain't that something? And I was proud to wear that because, yep, I am lovable and I am capable. And you convince yourself, you say that mantra to yourself all the time, over and over again. Wear the damn pin. Make one. ILAC. I am lovable and capable. Wear it. Say that to yourself, and you will become lovable and capable because you are lovable and you are capable. So when we take a look at our behaviors, I think one of the most important things that we need to do, minus the wise mind, and learning how to self-flagellate and feel good about yourself and all that, all these different skills, these mindfulness skills and what skills and how skills, and all this together, we need to make some links. We need to tie things together. We need to find the etiology of things. And then once we start to trace things back to when we don't do well, we need to change the direction. So we're looking at our behaviors, we're finding where the faulty behavior comes, and we're switching directions from that behavior. Okay? This is called the chain analysis. Okay? And what a chain analysis does, it allows your patient or you to explore the problem behavior that's in existence. If you've got parasuicidal behavior, You need to trace back to the time you weren't parasuicidal and then bring it up, your experiences on the point that made you parasuicidal. Why did you want to hurt yourself? What brought you up to that? What were you thinking? What were you feeling? What events were in your life? Trace it. Put the links together. And then what you do once you put the links together is you sit here and say, now, it started back here. I was calm. Over here is when I started to get in trouble. So now you take a look at your calmness to this point in time when you started to get in trouble, and you say, now when I start to have this feeling or this emotion, what can I do differently so I don't get myself in trouble, so I don't go to the next link in the chain? And then you change directions. You cut the link and you go in another direction. You build a whole new chain. And as you build a whole new chain, you get rid of this link and this one, this one, this one, this one, to the point where you get suicidal. You can do that with relapse. You can do that with assaultive behaviors. You can do that with depending on the pathology, with head banging, right? Because some people aren't in the autistic spectrum, but that's part of self-pain. They'll sit there, they'll start to bang their heads and dissociate, right? And then you have this therapeutic interfering behavior where in the therapeutic session, you're interfering with the process because something feels too good or too bad. But there's certain things, the therapist will say, then all of a sudden the therapist says something, it hits something inside, and now you become self-destructive. Well, you need to be able to recognize that. And you need to understand that as you're going through life, this is always going to be there, this point. So when you start getting the feelings that lead up to it, and you're starting to see a pattern in those feelings, what can you do to change direction? Analyze it, look at it. Look at the consequences if you buy into that behavior. If you do that, if you look into the consequences of buy into behavior, then you'll start to learn a little bit better. You're starting to see the sequence of events as they occur, the thoughts, the feelings, the negatives, the positive aspects of behavior. You're starting to look at all of these things. And as you start to recognize them, you're also starting to find solutions to them. You're starting to find ways to deal with them. That's a chain analysis. And they work wonderfully in all types of treatment. So one of the things that DBT involves is coaching and teamwork. You've got to be the coach. You've got to be the coach of the patient. Take the therapist hat off, put it over here, take the coach's hat on, put it over there, right? You as the individual therapist are the coach of the patient. And if you're in group, everybody involved in that group process, everybody is invited to be part of that patient's treatment. Now, therapists themselves in DBT have to be on or have to be in their own therapeutic process. That's part of being a DBT therapist, because you're going to be dealing with a lot of stuff, a lot of patients that are just going to drive you absolutely crazy. Patients that you think are making great progress, and the next thing you know, they turn you like a rattlesnake. Patients you think are making great progress, and the next thing you know, they're in the hospital with parasuicidal behavior or a suicidal attempt. You're going to be the great therapist in 1 minute, next minute, you're the worst thing that ever walked the face of the earth, and that patient just wants to destroy you. That's what can happen. So you need to get your own process, your own therapeutic process. And everybody that's on your team is also involved in that patient, because you can talk about the patients. Be careful how you do it, though, because of HIPAA violations, but it's done. And what your patients, your patient doesn't only rely on you. You've got to teach that patient to rely on others. And everybody that's in that patient's life that is dealing with that patient, you've got to coach them on how to deal with it, because there's nothing worse than, DBT therapists, or true DBT therapists, will give the patient their phone number. Sometimes it's, I don't know what they call those phones, the trash phones that you use a couple times. Use them a couple times, and you throw them away, right? Well, some therapists do that. They'll have a phone number. They'll give the patient that phone number and say, call me when you get suicidal. Well, good God. Back in the day, we used to have beepers, the little pagers that you stick to your belt. And every patient in the clinic had the phone number to that pager. I would be getting calls at 1, 2, 3, 4 o'clock in the morning, and I got to get up at 6 to be at work by 8. Could you imagine that if you got 3 patients like that? So the therapist, a DBT therapist, needs to really be in a DBT group of other DBT therapists to work through whatever they're working through. And the patients need to be in groups, and everybody within that group, they need to depend on to call to one another to build up their own support system in a support group. And they need to have skill classes. For example, one of the things I like to tell patients, write a diary. I do this with substance abuse patients. I do this with mental health patients. I do this with pastoral care patients. Write a diary every day. Bring it to me once a week, once a month. I'm the formation director for the Franciscan Order of our church. And when I put the people through the novitiate, one of the things they have to do is they've got to write a daily journal, and they've got to call me up once a month on the phone, because most of it now is on the telephone. Call me up once on the phone or do this Zoom type thing, and let's talk about what you wrote in the diary. It's all confidential. I'm not going to blab it to anybody else, and they know it. But I want to know what they are. I want to know what's happening to them. And they got to know what's happening to them, the good, the bad, and the indifferent, and accept it and work through the difficulties. If you see it, if you write it, you can understand it. The devils are gone. They're right in front of you now. And now that you see it, you can work through it. So you want to explore what you can do to reach that target behavior. Okay? Your daily cards. Explore that. If you've got parasuicidal or suicidal behaviors, put it down, work it out, write it out, and call somebody. Your mood changes, write that down. What caused the mood change? Tell me about it. And then tell me also what you've achieved, what kind of skills you've achieved to get away from all of this negative stuff. Now, you as a therapist, one of the things that you're going to have to do is you're going to have to contract with the patient that they're not suicidal. And that could be, it's got to be a written contract. Make it verbal, make it written, and make them sign it and make them put it in a prominent place that they can see it. But let them also know, because you got to build trust with the patient. If you're going to do this, let them also know that what they write is confidential. Now, the only way you're going to tell somebody, you let them know this, is if you're suicidal, homicidal, you sit there, you tell me that child abuse or elder abuse. Because as a mandated reporter, you've got to report those things. All bets are off the table with that. Make a commitment to the patient. And this is one of the hardest things therapists do. Make a commitment, because borderlines can be very, very tiring, and you just want to get rid of them. My old professor used to tell me, when you got a real borderline, when you want to kill them. That's when you got a real borderline. You just want to choke the life out of the person. That's not funny, but let me tell you, you get a borderline, that's what you're going to feel. Lots of anger. You better know how to deal with that stuff, or don't treat. Get the hell out. Patient can do that because the patient's allowed to be sick. You're not. Make sure, as a therapist, you tell the patient the rules and the expectations. What are the rules of treatment? What do you expect from the patient? And what are the consequences attached to them? But also understand that you are that patient's coach. 24 days, 24 hours a day, 7 days a week, 365 days a year. So when they run into something, they're going to call you. You're going to coach them. Set boundaries, or else you're going to get a call every 15 minutes. When can you call me? When can you not call me? Except in a dire emergency. And if it's not a dire emergency and you call me, I will hang up on you and I will see you in my office the next day. And if you get suicidal, don't call me, go to the emergency room. Of course, they'll call you in the emergency room, which is what you want. And you don't do that with the patient initially. You got to build up to that, but that's part of what you want to do. And also, one of the things you want to do is you also want to teach them the skill classes that I told you, right? Now, that's the full-blown DBT, the full-blown. You got a contract with them, make sure it's confidential, make sure that they have a commitment to you, to the recovery, to treatment, tell them the rules, explain the consequences, coach them 24 hours a day, 7 days a week, and teach them the skill classes. Then, for the patients that are pretty well self-maintained, right? Then you do the lighter version of it. You don't really need a contract. Your coaching becomes limited. Now, they're starting to take control, but you still give them skill classes to keep building it over and over and over and over and over again. So you go from the full-blown DBT to DBT light. And eventually what winds up happening is they get better. Okay. Now, for those of you clinicians that are in the field of forensics or want to be in forensics, you work with the criminal population. I used to work at San Quentin and also a Solano state prisons in California here. This works because you're going to be dealing with most of the difficult patients at a very high level of violence and high levels of self-harm. Some of your patients are going to be very suicidal, acutely suicidal. Some of them, if you're into this, I had the guys on death row, at San Quentin. Very high levels of violence, and you can't lose your temper. You lose your temper, that could cost you your life, right? So most of the inmates and patients at San Quentin have that I've noticed have personality disorders, along with their issues. They don't do well with standardized treatment, and they certainly don't do well with standardized traditional correctional standards. They just don't do it. So when we did treatment at San Quentin, the behavioral and cognitive therapies were often the best modes of treatment with that population. I had a wonderful partner, Dr. Parecki. Dr. Parecki and I used to work as a team together, and he taught me this stuff. And let me tell you, it was the most invaluable training I ever got with a job. Great guy, great psychologist. I swear to God, haven't heard from him in years, but great guy. And one of the things that he really pounded in my head was that behavioral and cognitive therapies work, and they're effective when treating this population, and they were. He introduced DBT to the California Department of Correction and Rehab. And he gave it, we both did it. He introduced it and I followed up with it. I created a program and he put DBT into that program that I created. And the results were outstanding. He had diary cards that he passed out to the inmates. We discussed chain analysis. We taught all the skills. We had groups in mindfulness, interpersonal effectiveness, emotional regulation, stress tolerance, and we put all of these things together. Mindfulness with interpersonal effectiveness, mindfulness with emotional regulation, mindfulness with the stress tolerance, all of this. And it seemed to work. It quieted down. When we were finished with that program, the violence in the program dropped drastically in that prison. And then when I left back in 2012 and he left a couple of years after, I don't know what it is right now, but from what I hear, it's a mess because they got rid of the program. One of the other things that you could do with DBT, if you like, is you can take a look at these different skills and play with it. Give quizzes. Give them oral, give them written. We did that. We had them we had the inmates, they're all in cages because it was death row and you don't want them out. So they put them in cages, locked the doors, and we had group in there. You get used to it after a while. And one of the things we used to do is we used to give them oral quizzes, you know, tell me your mindfulness skills, tell me your what skills, tell me your house skills. You know, what do you do with this? What do you do with that? What skill is this? What skill is that? How do you put this into play? How do you put that in play? You know, do what he used to love doing lightning rounds. Parecki used to love doing lightning rounds. You know, tell me this, you got 2 seconds. Boom, nope, boom, 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 boom. And they loved it. You could play games with this. You could do this. And when you're done to validate the people, you know, it's the little things that count. Give your patients a little certificate from you. Don't just pass it out. They got to work it. They got to earn it. But if they can comprehend and put into place the skills, you give them a certificate. Look at what happened with you, the therapist, and me, right? What kind of certificates do we have? We call them degrees. We put in the time, we do the work, we get the grade, we get that little piece of paper. Actually, a piece of paper is meaningless, but it's a piece of paper. That's all it is, piece of paper with words on it. But what's in here and what's in here is what counts. And that piece of paper says, you did a good job. You put it in here and you put it in here. So as you're working through DBT, and as you're working through this, go through trainings, go through workshops if there are any out there. Become a life coach. I'm a life coach. Become a life coach. Learn how to implement things into DBT programs. Create something. Make it your own. Allow yourself to be that individual that can treat, that can help, and that can work with the patient. Be mindful of what's going on with you. Teach the patient to be mindful of what's going on with them. Okay, it's been a long time. I hope you got something out of this. And I hope that you broke this up along the way because this is a rather lengthy video. But at the end of this, you'll receive a little certificate. And this is going to be part of continuing education for your credential if you go through InterCoast colleges, through myself and Judy Redmond. All right. So thank you. Take care. And go DBT. Bye for now.